lecture, your voiceover PowerPoint lecture regarding topical medications. Um, you need to refer to your Introduction to Clinical Pharmacology textbook when you are studying for this topic. Not one entire chapter per se, but I do have 2 chapters written down on here. I want you to look at chapter 4, pages 56 to 61. And then I also want you to look at chapter 18, pages 329 to 339. I want you to read through that chapter, but not focus as much on the 5 groups of drugs or our drops for glaucoma. Mainly the point of this lecture is to just talk about different kinds of topical medications or percutaneous medication that goes through the skin and mucous membranes so you can become more familiar with it. If you listen intently, you will notice there's a lot of similarities to what instructor Vincent has already lectured on. Just know that that's a reoccurring theme. She and I do collaborate together just so that you guys can have repeated layers of knowledge with regard to the lectures for test taking purposes. So if you have any questions or if you see anything that might be a little different from what instructor Vincent said, please let me know. Learning objectives from these 2 chapters combined is just to identify major categories of medications used topically. We're going to describe specific administration techniques for different types of topical preparations. We're going to list preparations used to treat eyes, ears, nose, and skin problems. We're going to explain what types of drugs are used topically to manage eye problems, describe the proper technique to administer eye drops and eye ointments. We are going to talk about glaucoma and how drugs are used to prevent an increase in intraocular pressure in the eye. Glaucoma is something that we're going to revisit again this semester, so I would pay attention to that whole process. We're going to describe proper technique to administer drugs in the ear and explain what types of drugs are topically used to manage ear problems. So in essence, this lecture is really a brief overview of the many products that might be used topically somewhere on the skin or on your mucous membranes. Remember again that that is percutaneous administration or topical medications. For the purpose of our class, we'll just remember topical medications. You may hear percutaneous out at the skilled nursing facilities or again, 3rd semester. Many of the products that we're going to talk about can be purchased over the counter. And as nurses, we play a major role in teaching the patient proper administration of these medications and precautions for their use. Side effects for topical medications are usually local. So that is pertaining to whatever area that we are putting the drug on, especially if it's on the skin and not over a mucous membrane. Occasionally, we can have systemic side effects for medications that go through a mucous membrane, but for right now, I would say they're usually local or just kind of gathered in one area where we put the medication. Absorption is what happens with regard to the mucous membranes. We could put a buccal tablet in our cheek. We could put a sublingual piece of film, medicated film under our tongue. We have mucous membranes that are going to absorb that medication and get it into our system a little bit quicker than it would happen if we were taking a PO med. Inhalation, we inhale either via a metered dose inhaler, which I want you guys to pay attention to with regard to this lecture in this chapter. Nasal inhalation, something like that with regard to with regard to mucous membranes. There are pastes that we put on our body. We have patches. We have estrogen patches, birth control patches, patches that help us to stop smoking. We have fentanyl patches that are supposed to help with pain relief. We have suppositories that we will use rectally, that we'll use vaginally to help us with different things that we need to have done with our bodies, and we'll talk more about that as well. There are drops that we put in our eyes, that we put in our ears, that we put in our nose, and sprays. And I said sprays up above with inhalation. But we have sprays that we put in our mouth. We have sprays that we put up into our nasal passages. So there are lots of different ways that we can use topical medications. And this all should sound pretty familiar after listening to instructor Vincent's lecture the other day. Many of these preparations can be over the counter, which means you could go down to the local grocery store and buy, a spray that might help you with a sore throat or something like that. And we're going to talk about the nurse's role with regard to our patients and educating medication administration and what we need to do to help our patients with these preparations. So the first thing we're going to talk about is transdermal topical drugs. And these are drugs that go across the skin, basically applied to the area requiring treatment. With regard to an adhesive patch that gets stuck to the skin, the medicine goes from the patch across semi-permeable membranes and is absorbed into the bloodstream from wherever it is that you put the patch. We're going to be talking a lot about this in lab this week. If we haven't already done it, we are going to be practicing with patches and whatnot. So Instructor Vincent and I will be helping you with that so you can have a hands-on approach to it as well. So if you review page 56 and page 57 in chapter 4 of the Introduction to Clinical Pharmacology book, you will find some steps for applying transdermal patches on these 2 pages, and you will find some diagrams that kind of show you how these are done. I do want you to review figure 4.23 and 4.24 on page 57. Some things that we need to consider with regard to applying these patches is the skin condition of the patient. Is the patient extremely hairy? Is the patch going to stick to whatever area we choose to put the patch on? In some cases, we might have to take an electric razor and kind of take off, the hair around that area just to get enough of a sticky type of adhesive action going on to keep the patch in place. Otherwise, the patch is just going to fall off. It could cause problems if there's a drug on it, say like fentanyl or nitrostat, right? That could potentially seep into the skin of whomever picks up the patch. So we need to think about that. Are there any open lesions in the area? Are there any abrasions, scrapes, scars that are open, incisions, anything that might potentiate or make the absorption of the drug go quicker? We don't want that to happen, right? Is there any kind of scar tissue? I already said scar, but what I mean this time is hard, repairing type of skin action going on in that area, because you're not going to have a lot of circulation to that area where there is skin that is being repaired, and it could potentially put a damper on the absorption of the drug to that area. So we need to watch that. Additionally, wiping off the medication that was there before. If you're putting something back in the same spot, we need to do that to make sure there's not an excess of medication to that area. And it also helps with the sticking of the patch. In some cases, we do have to rotate patches. So if we're rotating, we need to make sure we're teaching our patient to keep track of where the patches have been. If we're putting the patch on ourselves as a nurse, we need to make sure that we date and put our initials on the patch, date and time. A lot of these patches are supposed to be changed at certain hours, so that the clinician coming in behind us will know that it has been done, and documenting that we've changed it and put it into a different spot. Lastly, you need to be wearing gloves as the clinician, or whomever's putting the medication on the patient needs to be wearing gloves so that the medication doesn't seep into their hands as well. So I want you to go over page 56 and page 57. We'll talk about it a little more on the next slide. So it looks like I've already talked about this slide on the previous slide. So please go through chapter 4, page 56 and 57. Read through the instructions for transdermal patches. You may see some test questions with regard to those. And focus on patient education with regard to administration in the home. There is a box on page 56 of your book, box 4.2, that says giving percutaneous drugs on it. And it talks about preparation and giving the drug, step 1 and step 2. And go through that box. Make sure that you kind of understand why and what we do with regard to the steps that are listed in that box, because we'll be revisiting those steps throughout the semester. So it'd be really good for you to review that box and kind of put that to memory. Additionally, the nitrodur, the nitroglycerin that you see in this slide, and the application of the paste on the piece of paper that is in the upper picture on the slide. This is something that we probably will be practicing in class. So if you have any questions with regard to this, this is on figure 4.23 on page 57, and just ask us in class. So what I want you to remember is when you're doing drug administration through mucous membranes, there's generally a good rich blood supply to whatever area that you're administering the drug to. With regard to sublingual and buccal, usually administering in these two routes get through your system a little bit quicker than if you swallow a pill. So one thing that you need to remember with regard to putting something in a patient's mouth is to make sure that they know that they should not eat or drink anything until the medication that you put in their cheek or underneath their tongue. So in the cheek, between the cheek and the teeth, there would be the buccal, and then sublingual would be under the tongue. Make sure they're not eating or drinking anything until those are fully dissolved. The other areas, vaginal, rectal, eye, ear, nose, respiratory system, all of that, those are all really good areas where we could put medication and it could become effective rather quickly. There are boxes for administration of all of these routes, and I want you to look through these. I believe that Instructor Vincent has talked to you about this in class already, and we're going to be doing some hands-on application of these drugs in class as well. So go to page 59 and review box 4.3. Page 60, review box 4.4. Page 61 and review box 4.5. And just become familiar with those. So all of those have administrative instructions for these routes. We're going to talk a little more about nose here upcoming. So let's kind of talk about some of the things that we would administer in those particular areas. Mouth and throat preparations. You could have forms of mouth and throat medications such as oral preparations, lozenges, troches, any kind of gargle that you might have to do, gels, mouthwashes, and sprays. The general action of these drugs is usually to soothe minor inflammation in the mouth and release oxygen to provide cleansing anesthetic properties to whatever area that you need to have relief in. Remember, the troche is like a cough drop, or like a Mike likes to treat oral thrush. You just put it in your mouth and you let it dissolve. And sometimes those will just go buccally right in the cheek, between the cheek and the jawline. We're treating inflammatory conditions, canker sores, dental irritation. If somebody's having pain after dental procedures, it might numb the area, make it feel better. sore throats, and control of cough caused by colds. So make sure that you're reading the instructions for administration and teaching the patient the appropriate administration technique for whatever product it is that you're using. Additionally, and something that I really want you guys to remember is that patients should not use these products for longer than 3 to 4 days for normal therapy. If things continue to not feel good after 3 to 4 days, they should be calling a doctor and seeking further medical treatment. I've thrown some slides up in here just so you can remember one more time what each of these routes are. So sublingual could be a tablet, like an oral disintegrating tablet that you put under the tongue. Ondansetron, which is an antiemetic, it's used to control nausea, something that we frequently give at the hospital or even in skilled nursing facilities. It just dissolves under the tongue and it works well, right? If somebody is sick and they're throwing up profusely, you're going to want to put something under their tongue. If it goes into their mouth and they swallow it, then they're just going to throw it right back up and it's not going to work correctly. So remember, sublingual could be tablets, it could be the little films that dissolve underneath the tongue, but that's where we put it. And this slide has the disintegration of the buccal tablet as well, and it just is a time lapse series of 4 pictures of this tablet disintegrating in the patient's cheek, between the cheek and the jaw. So you can see that even after 6 hours, this tablet is still sitting there, providing relief and helping this patient. This should be review as well. Vaginal medications are listed, or a description of what we're doing with vaginal drugs are on page 58 in your book. We generally give these drugs to treat infection to whatever area might be going on vaginally. We also administer something like estrogen hormones, different things like that into the vagina as well. These type of drugs can come in creams, jellies, tablets, foams, or suppositories. Those are examples of certain types of vaginal drugs. What I want you guys to remember is to make sure that you're always wearing gloves when you are administering um, these type of drugs. You might be using an applicator, or you might have to insert your hand up into the area to put the drug up in there. It just gets pushed up in. There's no sphincter or anything like that in the vagina, so we just have to push it up into that area. On page 60, box 4-4, up at the top, there's a diagram and some instructions on preparing and giving vaginal drugs. So I would like for you guys to go over that. It does say to make sure that the patient remains lying down for 10 to 15 minutes so that all the drug can melt and coat the vaginal walls. Sometimes we'll put a peri pad underneath of a patient just in case there's any drainage or staining that might occur from giving the drug. So please review box 4-4, page 60. So suppositories that can go up into the rectum are used for are called anorectal medications. They could be suppositories, they could be emollients or foams, gels, basically inserted either, like I said, via suppository or through an applicator up into the rectal area to heal the rectum. And what these drugs do is they provide symptomatic relief of hemorrhoidal discomfort. And we can use them quite often or for just a short amount of time. But what I want you to know is that hemorrhoids in the rectum area can be quite painful. Basically, what they are is they are bulging of the veins in the rectum. They're called varicosities. You guys will hear that word in med-term again, but just basically big bulging varicosities inside of the rectum. Veins that get damaged when you're passing stool, if a patient is pushing too hard to pass or have a bowel movement, can cause damage if we've got a big amount of stool coming through, cause rips, tears, injury to the vessels in that area, and they swell up, and they can either be up in the rectum or they could be kind of protruding out of the rectum, and they are very painful. So we put steroids up in our body, um, other kinds of medications to numb, to repair, to basically repair and take down the swelling. Itching is another reason why we would put medication in the area. Um, a lot of elderly people have a difficult time having a bowel movement when they've got hemorrhoids. It's just so painful. They don't want to go. Can lead to a bunch of problems with regard to constipation, impaction, different things like that. If you look in your book on page 61, there is a chart about giving rectal drugs and the procedure. This is an enema. On this slide, actually, an enema is another drug that we would give, and that would be to help relieve impaction and have a patient have a bowel movement. On page 60, box 4.5, there are steps for giving rectal drugs. There are certain ways that we want the patient to lay, which is generally laying on their left side with one leg bent over in the Sims position. And we have to remember, as a nurse, we need to protect the modesty of the patient. Always use gloves. This is not a sterile procedure, so you don't have to have sterile gloves. Obviously, it's kind of in a area where a lot of waste is expelled from the body, so it's not a sterile procedure. But we're trying to give relief from constipation, relief from the hemorrhoidal pain that a patient might have. Um, Being constipated is a horrible thing. It can cause nausea, vomiting. It's just very uncomfortable. So that's why we would give these drugs. So this is a simple A and P correlation here on this slide. We're going to be talking about eye problems. And eye problems could be attributed to the eye itself, or it could be attributed to the brain. It could be attributed to the optic nerve that goes from the eye to the brain. They work together. The eye basically shoots images through the optic nerve to the brain, and that's how we allow sight. Drugs that we're going to talk about are called ophthalmic drugs. They come in liquid drops. They come in ointments, and we either place them on the eye or we place them on the conjunctiva of the eye. And you could see up here in this picture, this is a picture of eye drop administration. The conjunctiva is right above the finger on the, well, there's only one finger there. So it's right above the finger, just on the inside of the eyelid right there. If you have any questions with regard to the conjunctiva, please let me know. So we have lots of different ophthalmic drugs that we can administer in the eye. Lots of different categories, drugs for local anesthetics, antiseptic ointments that we might put on the inside of the bottom lid, ophthalmic anti-infectives, so some sort of eye antibiotic drop that we might use. We can buy artificial tears over the counter just for dry eye, just to make everything a little more hydrated in the eye. Anti-glaucoma agents are also a big one that I want to focus on in this lecture, namely timolol, which is a drug that I had you guys write down on your cards, and other types of agents. So basically, let's focus on anti-glaucoma. I want to talk about intraocular pressure and how it causes problems to the eye, but know that there are these other forms as well. If you pull up this slide deck in PowerPoint and view slideshow and hover over the word glaucoma in whatever color that is, yellow ochre, that's what I'm going to call it, yellow ochre. You will see a YouTube video that explains how glaucoma happens. There are two different ways you can have glaucoma, and we'll be talking about that later this semester. But what happens in a nutshell basically is that the fluid in the eye, there's a problem with it draining, and it's either because of a blockage or it's because of some kind of trauma to the eye, and it causes too much intraocular pressure to go into the inside of the eye. So the fluid continuously kind of runs through it and circulates through it. When it's not draining out, the fluid gets fuller and fuller and fuller until the optic nerve of the eye has pressure being put on it. The optic nerve wraps itself around the outer area of the eye. And as that happens, you start to lose your peripheral vision. So over time, as you can see from the top set of pictures, the first one is normal sight. And then you have early glaucoma symptoms setting in. You can see the black up at the top of the screen, and advanced glaucoma as it happens. It gets um, considerably worse and progresses over time until after a while you have no peripheral vision, and it's like staring through two little peepholes trying to see everything. So we give drugs and drops to treat glaucoma in a variety of different ways through a variety of different mechanisms to control that outflow of the fluid in the eye. For the purpose of this lecture, all I want you to know right now is that the fluid builds up in the eye, causes pressure, and we have to try and control that. Glaucoma is not reversible, so we use these drugs to prevent it from progressing or to slow that progression down a little bit. So there are 5 categories in your book of drug groups, and for purposes of our class this semester, I want to just focus on one, and that is the beta blocker group and the drug timolol that I had you guys writing down. So let's go to the next slide. All right, so here are the 5 groups I was talking about in this chapter, which is chapter 18. You can read more about these classes of drugs. The only one that I want you to really focus on for the semester is beta blockers and the drug timolol, which you guys should have already looked up and will bring to class on the day that it's due. And basically, what timolol is used for is to treat high pressure in the eye due to glaucoma. Um, Basically, what you could equate glaucoma to would be intraocular or ocular hypertension, right? So there's too much of a flow, too much pressure going on in the eye. The purpose of timolol is to lower high pressure inside the eye, and we want to prevent the progression of that pressure on the optic nerve and the progression of glaucoma from happening. Remember, I said that it was um, not reversible. So how it works is it just decreases the amount of fluid within the eye. Works with the beta cell or the beta receptors in the body, blocks those and keeps the vessels kind of open so that more can flow through, and it reduces pressure. Beta blockers can work in other areas of the body as well and can affect the heart. So we have to be careful with patients who say have heart failure, different things like that. So cardiac wise, we would have to assess for a cardiac history, make sure that it's appropriate for that patient. We'll be talking more about timolol in class. The other ones are the sympathomimetics, direct acting miotics, cholinesterase inhibitors, carbonic anhydrase inhibitors. Aren't you glad that I only have you guys focusing on beta blockers? Yay, Instructor Robinson. So I really like the way that this book has huge diagrams and boxes that show you step by step how you guys should be administering these drugs. And I know Instructor Vincent has pamphlets and handouts that she's giving you as well. I would definitely take the time to pay attention to the administration of eye and ear drops, eye ointments, different things like that. You will see them multiple times on your tests this semester. So I would know how to do that. I have put down the pages and the box numbers for eye medication administration, what nurses should be looking for when they do it. what they should be doing when they're taking the steps to make sure that it's a clean administration and whatnot, and what kind of education we should be giving our patients and family when we are doing this. So please review these boxes. This is all testable material. I want you to do that on your own time. I've given you really a roadmap to what you need here for test taking purposes. If you have any questions, please do not hesitate to let me know. So this is not an A&P class, right? I keep telling you guys this, but I really believe that there is some kind of weird um, plan in life when all of our body parts were put together, that there's some kind of higher form of direction going on when humans were made, because every part of our body, it seems, has its own specific job or reason why it's on our body, like it, like a higher being thought it through or something. I don't know. It's kind of weird when you think about it. But with regard to the ear, what I want to tell you very briefly, because Mr. Miller will talk about ears and how these all work, all these parts work together in conjunction as a team to allow you the privilege of listening to me, um, how everything works in conjunction. So you have the external ear, which is the outer area of the ear there. The pinna is what I'm pointing, or at what I'm looking at right now. The external ear canal going to the tympanic membrane. That's all the middle ear. And then the inner ear is the auditory nerve, the cochlea, the stapes, the incus, all that stuff. And how the outer ear gathers the sound and filters it and takes it into the tympanic membrane. It's just really kind of cool when you look at it. And then the auditory nerve obviously collects all that data and sends it to your brain, and that's how you decipher all of the amazing things that I have to say to you. So, at any point in time, something could become infected, injured, something could be wrong, which there might be an impaction in there of cerumen, which is earwax. We are giving drugs in the ear to help that problem, and these drugs are being administered topically. I'll step off of my wow, that is a really cool thing soapbox and talk about ear pharmacology. Now, I heard instructor Vincent say this the other day, and I want to repeat it. Drugs that treat ears are called otic drugs, and that is not the same as optic. Optic are eye drugs, right? Otic are ear drugs. And we can get these drugs via prescription. We can get them over the counter as well. And we're talking about drugs, drops that will control inflammation in the ear. We are talking about drugs that control superficial infections of the ear. I'm sure some of you who are parents have had to put ear drops in your children's ears if they've had an ear infection at some point in time. The slide says that superficial infections can be bacteriostatic or bactericidal. These are two terms that you will hear later on this semester. They appear on this slide right now. You will not be tested over bacteriostatic versus bactericidal this time, but you will need to remember that this semester. So remember, bacteriostatic is a drug that prevents the growth of bacteria. If something isn't growing or getting larger, it's static, right? It's not being killed off, but it's not getting bigger or worse. So bacteriostatic. Bactericidal means it kills bacteria. So remember, homicidal, killer. Bactericidal is a killer, okay? Some of the uses that we have, the otic preps have many uses. So like I said, infection and inflammation, middle ear, external ear, different things like that. We can use these drugs for excess buildup of cerumen, which is the earwax that I had mentioned earlier, and you can see the debrox in the picture there. So it's important as a nurse to follow or to educate patients to follow package insert directions for administration guidelines. We have steroids that we can put into our ear. We talked about antibiotics already. There are lots of different things that we can do to help a patient recover and have less pain just by treating ear problems. Earwax that's impacted in the ear is very common, especially in the elderly and little kids. It can cause hearing loss, it can cause pain, and it can cause congestion as well. So these are things that we definitely need to focus on. On page 331 in your book, box 18-1, I want you to review thoroughly the technique for instilling eardrops into a patient's ear. We will be practicing this in class. There are a few things that I want to point out that are different with regard to kids versus adults. We have the patient lie down with the head turned so that the effective ear is turned upward. If the patient is sitting in a chair, we tilt the patient's head so the effective ear is up. For kids younger than 3 years old, we pull the pinna, which is the outer area of the ear, down and back. Look at the picture down at the bottom of the baby, picture B, and follow those instructions. Put a cotton ball into the opening of the ear canal. Keep the drops from coming out of the ear. For adults or older children, we pull the pinna up and back. So there's a distinct difference there. I want you to look at both the picture of A and B. That might be something that you will see again at some point in time. Remember, we roll this medication in the palm of our hands. We never heat it up. We never give cold medication that can cause pain or discomfort to the patient. And we wash our hands afterwards. With regard to eyes and ears, never touch that applicator if you can to any part of the patient's body. That's something else that I want you to remember. All right, drugs can be given and inhaled through respiratory mucosa. Common types are aerosols for inhaled drug delivery and pressurized metered dose inhalers or dry powdered inhalers, and we will be using these and practicing with these in class. Faster effect of the drug can happen when delivered directly to the respiratory mucosa. So it is super important for us to teach a patient how to correctly use a metered dose inhaler. There are a lot of things that we need to look at and give note to when we're talking to our patients. I want you to review page 58, table 4-4. It's difficult sometimes for the patients to coordinate hand and breath action needed to dispense the drug, so a lot of teaching is involved with regard to these drugs. The other thing is the mouthpieces that they use might become contaminated. We need to make sure that they're clean, that they're washed. In other situations, we use spacers, which basically allows the medication to go into a space between the applicator and the patient's mouth so that they can get all of the medication into their system. There are dry powder inhalers with little capsules that they have to poke with a needle. It's all in the mechanism of the applicator. We have to teach them how to do that. And lastly, we have to teach them how to take multiple breaths with their inhalers and rinse their mouth out after some forms of medications, say like corticosteroids. They can cause problems such as yeast and whatnot. We'll be talking a lot about each of these in class. What I do want you to get out of this slide is that if you're taking more than one drug, you're going to wait between 2 and 5 minutes before you take the next one. You're going to instruct the patient to take a deep, deep breath and blow out everything in their lungs before they administer the medication into their mouth. And then you're also going to have them rinse their mouth at the very end just to get the medication out of their mouth so it doesn't stay in there. All right. It wouldn't be a Dina Robinson lecture if I didn't have something in my lecture that didn't make you go gross when you look at it. And that would be this page. So, topical skin preparations, I'm talking with regard to medicated bar soaps right now, foams, topical antibiotics, acne medications. There are steroid medications that we can rub into the skin. These things are used for dermatologic disorders. Preparations can be over the counter, they can be prescribed and can be mild, intermediate, or have a very strong concentration. Um, Psoriasis is a skin condition consisting of red and silvery scaled maculopapules, and that's the top picture that you see up there. We'll see a lot of patients with skin conditions like this. And we would use something called an anti-psoriatic. Accelerates the scaling and the healing of dry lesions in chronic psoriasis. You guys see these drugs on TV all the time where the lady's all covered up with a sweater, and then the next thing you know, she's out on the town in a tank top and her psoriasis is healing. Um, Scabies is the middle picture that you see there. That might be something that you would see. Scabicides are used to basically treat scabies and just kind of fix that little rash from an eruption that might happen. Pediculosis is lice. Anybody with children in the room or listening at home, have you ever had to deal with this? Uh, Pediculicides are used to treat pediculosis. So these are just topical applications in the hair, and I think we all know the process. If you've had kids, how we get rid of this. It's a topical shampoo. You put it on, it kills off the infestation. And by the grace of God, you don't ever have to look at it again, hopefully. These are just some examples I kind of wanted to throw in at the end as well. All of these situations and examples are all forms of topical medication. So be sure to ask your patient if you are doing a medication reconciliation. All of these things we need to know about. Any kind of over the counter, any kind of prescriptions. Sometimes patients forget these forms of medication that maybe might not seem so serious to them. So we need to make sure that we are really thinking outside of the box and making sure we're asking questions about any complementary, any alternative therapies, any over the counter types of things that they might be using. So after reviewing the administration techniques for eyes, let's answer this question. Which statement by a client indicates a need for further teaching regarding proper administration of eye drops? This is a question that you might see on a test. It's called a negative statement question, or what we are looking for is a negative statement. We're looking for something that the patient or the client would say that is not correct. So your keywords are a need for further teaching. So A, I will be careful not to touch my eye with the dropper. Is that right or is that wrong? I'll let you decide on your own. B, I will rinse the eyedropper with tap water after each use. Is that right or is that wrong? C, I will press gently against the inner corner of my eye after I administer the eye drops. Is that right or is that wrong? And D, I will wash my hands thoroughly with soap and water before putting in the eye drops. So, is that right or is that wrong? The answer is B. The reason why it's B is because if you aren't touching the dropper to anything, there is no need to clean it after every use. Additionally, it just gives more of an opportunity to have it touch something else and have, it potentially affect your eye. You're not supposed to touch your eye with the eyedropper. You are supposed to press gently against the inner corner of your eye after you administer the eye drops. It prevents it from going systemically into your system. And you should wash your hands thoroughly with soap and water before putting in eye drops. So the answer is B. Okay, the nurse base is the plan of care. So the plan of care is the map of care for the patient that the nurse is working on. The nurse base is the plan of care regarding administration of eardrops on what knowledge. The instructions and technique for eardrops are on page 331, box 18-1 in your book. A is the pinna of an adult should be held down and back. B says eardrops may be warmed in the microwave before administration. C says proper administration includes holding the pinna up and out in an infant. And D, warming the eardrops to room temperature before administration helps reduce a vestibular type of reaction. So what I want to show you with regard to this question is A and C are kind of similar. It talks about administration for adults versus children. And usually if you have two answers that are sort of similar, sometimes, I'm not going to say every time, neither one of them are correct. And the reason why A and C are not correct is because they're completely backwards. So with regard to A, the pinna of an adult should be up and out. And with regard to C, the pinna of an infant should be held down and back. Look at the pictures on the bottom of page 331. B, eardrops may be warmed in the microwave before administration is never right. We never warm up anything in the microwave because you could cause a lot of damage. Things heat unevenly. We do not want to do that. What we would do is we would warm up the eardrops to room temperature to reduce a vestibular type reaction. And D is the right answer. The reason why we wouldn't warm them up in a microwave is we could hurt somebody. So we would roll them in our hand and just make sure that they get nice and warm before we administer them. These are the references that I used for this lecture. Please make sure you have your 2 drug cards in class for next week. If you have any questions with regard to any administration or anything that we've done, drug administration, any technique that I've talked about here or that Instructor Vincent has talked about, please reach out. Thank you.